Should I start?
Yeah.
Okay. This is Rebecca Roper from the Agency for Healthcare Research and Quality, and I have the pleasure of introducing Dr. Michael Parchman and Dr. Lyndee Knox, who are going to give a presentation about PBRN Workforce of the Future. Had I been, I should have just brought the Star Trek theme to introduce these folks as they lead us into where we're boldly going ahead. So that would be wonderful. Dr. Parchman is a particular fan of Star Trek, so I'd like to tease him about that when possible. So they will be speaking at length for about an hour and maybe a little longer, and welcome any questions that you may have. So let's go over how you can pose your questions. If you look at your web link, you can submit a question by going to the questions section, which should be on the right-hand side of the control panel for GoToWebinar. Type your question and send, and press the send question. Our colleagues at ACT will help facilitate sharing those questions with Dr. Knox and Dr. Parchman as they are able to, in batches, and respond to questions at the end of the presentation, or they may be inspired to respond as they go. But I imagine that the question and answer, they may choose to delay to the end. You will also notice in the presentation that they are going to give you links to some wonderful references on the AHRQ webpage, and I ask you to pay particular attention to those, and we can share those with all participants. When we sent out the notice for this particular webinar last week, and we resent it, we only had 9 forward-thinking folks who had signed up, and we had an explosion of response of 100 people indicating their interest and their willingness to join us on what is a very hot day on the East Coast. So we're so glad to have Drs. Parchman and Knox from the West Coast leading us in this discussion. And with that, I will say thank you for joining us, and I will turn it over to Michael and Lyndee.
Dr. Roper, thank you so much for that introduction. Let's see. So, Kristen, I'm supposed to run these off of mine because it looks like you're sending them to me. Is that right?
Yes, that's right.
Okay. All right. Hold on. Sorry about the technical glitch here. Not my forte. So I want to thank you all for participating and joining this session that the Learning Collaborative with the PBRN Resource Center. And today, Mike and I are going to be talking about the PBRN's evolving role in the U.S. and in primary care practice improvement and the workforce that's needed to support this work in the future. So, Mike, with that, I'd like to go briefly over the agenda and then turn it over to you. So the first thing we're going to talk about is just a brief overview of PBRN origins. Then the current or the recent PBRN expansion in the last 10 years, the new and evolving role and vision for PBRNs, especially as it relates to infrastructure for practice improvement and transformation, and then the new type of PBRN skill set and workforce that will be needed to support these roles. Then we'll do a brief wrap-up and then open the floor for questions and discussions. Again, because the participants are muted because of the large attendance, if you would submit your questions using the chat function, as Dr. Roper outlined, then Mike and I can respond to those. So Mike, take it away.
Great. Thank you, Lyndee, for that introduction. So we're going to just give you some background about why PBRNs exist real briefly, and then about what's happened over the last 10 to 15 years with their expansion, just to give you the context for where we're going with looking forward to the future. So many of you know this story, but some of you may not. Some of you may be new to the PBRN community and may not be fully aware of this. So this slide shows a very famous diagram called the Carr-White diagram and the ecology of medical care. Carr-White was faculty member actually in North Carolina and was a family physician, a primary care physician, and was told there was no role for primary care in research, basically. And this was early in the 1960s. he actually did a study using some early databases that were available about the ecology of medical care in the U.S. that basically demonstrated that if you have 1,000 people in a community, in a typical month, 750 will have an illness or a concern. Of those 750, 250 will actually see their personal physician. Of those, 10 are admitted or referred to a hospital or referred to a specialist. And of those 10, only 1 gets admitted to an academic health center, tertiary care center. Now, back then, all research was occurring at the academic tertiary care center on that one person. Part of the rationale for starting the PBRN movement was to move the scope of research back out to that square where 250 were seeing their personal physician. Because much of the research that was being done was not answering questions that were relevant to primary care clinicians at the time, nor were they being done on the typical patient population. They were being done on that one person who was admitted to the tertiary care center. So next slide, Lyndee. This is one of my favorite quotes. This is Lawrence Green, PhD. Some of you know Larry Green, MD, but this is Larry Green, PhD, who said, you know, if you want more evidence-based practice, we need more practice-based evidence. This is the idea of doing the research in the setting where most of the people receive most of their care most of the time, which is one of the reasons why PBRNs exist now. Next slide. So this is a early definition of a PBRN, an organization of primary care clinicians researchers united by a shared commitment to expand the science base of primary care practice through systematic inquiry. We're going to revisit this definition later in the presentation and talk with you a little bit about a new vision for PBRN. So next slide. Early PBRNs in the U.S. included the Ambulatory Sentinel Practice Network, or ASPN, as it was known back then, a national network of mostly family physicians. It was actually supported by the American Academy of Family Physicians, the Dartmouth Co-op in the Northeast, the Pediatric Research and Office Settings was a national network, and then the Wisconsin Research Network was a state-based network. If you've not read the article on a short history of primary care PBRNs, I'd encourage you to look at this one. This is from the Journal of the American Board of Family Medicine in 2006. The lead author on this, Larry Green and John Hickner, they do a great job of telling the story about how PBRNs got started and where they are now. So next slide. So we talked about why PBRNs were created. This is a good example of why PBRNs were created. This is the ASPN network, their study of carpal tunnel syndrome. This study was done back in the early 80s and was designed to ask the question, what is the typical course of a patient with carpal tunnel syndrome, and what management strategies seem to be effective? Back then it was thought people with carpal tunnel syndrome uniformly needed to be referred to an orthopedist for surgery for release of their carpal tunnel syndrome. And this study was able to definitively prove that carpal tunnel syndrome, in fact, was often self-limiting in nature, often resolved on its own, and conservative therapy could be used to manage many patients with carpal tunnel syndrome. So this is an example of the kind of studies that were answering questions that were relevant to practitioners, full-time practitioners who were in primary care, thinking about responding to their questions and their needs. Next slide. PBRNs began to rapidly expand. If you look at the growth of PBRNs, we went from 28 active networks back in 1994 to currently over 157 primary care PBRNs registered with the AHRQ PBRN Resource Center. Fairly rapid explosion, a lot of it due to support from AHRQ over the last 10 to 15 years. This just gives you some of the highlights of things that have been developed in their growth with theme issues, with supplements to journals, and then the annual theme issue of the Journal of the American Board of Family Medicine starting in 2006. Next slide. And here's a map giving you some example of their spread or their distribution across the U.S. So these are both the regional, and some of these represent the national offices for national networks about where they're located. And you can actually see this on the PBRN Resource Center website. But this is the current map about the distribution of PBRNs in the U.S. Next slide. So this then leads us to where we are now. So where are we now and where are we headed? PBRNs for many years have been mentioned as playing a key role in translation of research into practice. Some of you may remember TRIP grants, Translation of Research into Practice grants, many moons ago, and the role that PBRNs played in some of those early grants. The language has gradually evolved to talk about going from translation of research into practice to thinking about dissemination and implementation. And from there, we've gone to thinking about practice transformation or practice redesign. And now we're talking about not only practice redesign as a one-time event, but ongoing practice improvement as continual improvement and continually improving the delivery of primary care, both the quality and outcomes of care. Next slide. Indeed, back in 1996, the IOM, the Institute of Medicine, said PBRNs are really the most promising infrastructure development that they could find at the time to support better science in primary care, better delivery of primary care. Next slide. And then in 2007, Jack Westphal and Jim Mould published an article in JAMA. This was back at a time when the NIH was redoing the way it thought about supporting infrastructure and academic health centers. And they developed the Clinical Translation Science Award. And this article was in response to that early work on this NIH roadmap, which really showed the position that PBRNs can occupy in this translational pipeline, which instead of going from basic science, which is bench, to human clinical research, which is bedside, to bookshelf, which is publication of the journal article. So instead of going from bench to bedside to bookshelf, it's going from bench to bedside to community. How do you get improvements? How do you get findings? How do you get redesigned ways of delivering care out into practice in the place where most primary care is delivered in the United States? And practice-based research or practice-based research networks were identified as a promising vehicle for that in this article. Next slide. We've now gone even a step beyond that. It's no longer just thinking about how do you disseminate research findings into practice. As PBRNs are basically a network that is a participatory network. You remember the definition we talked about, that PBRNs are a unique collaboration between practicing clinicians, practicing physicians, and researchers, right? That's a two-way street. By their nature, PBRNs are very participatory. They respond to the needs of their members. And it actually comes from the very early origins of the PBRNs, where they were saying, you need to listen to people who are doing the care and asking the right question to do your research. Because if you ask the wrong question, you get the wrong answer. So how do you engage clinicians at the front line of care in asking the right question, in designing the study, and interpreting the results? And that very participatory nature has also led PBRNs to listen to their members and say, what are their needs? And actually work with them in terms of their role in quality improvement and practice change, in continuing professional education, in helping retain clinicians in medically underserved areas, a role in actually informing and facilitating actual health policy development is also suggested in this role. And so Rob Williams and Robert Ryan wrote this article, came out in 2011, about PBRNs are not just research networks, they're also improvement networks. Next slide. And there's actually a growing body of literature that supports this and evidence that supports this, that PBRNs are playing a role in improving practice and in clinical practice change. Whether they were designed originally to do that or not, that is a role increasingly that PBRNs are playing. They're sort of, by default, having to fill a gap that's out there. Because right now, oftentimes in many places, there is no infrastructure for primary care improvement. So PBRNs are responding to the felt needs of their practice members in filling this gap in terms of saying, how can we be involved with you in improving the quality of care you deliver and in helping you redesign your practice. Next slide. There were several developments over the last few years that have really placed this, that are really drivers of change in this process, in this evolving role of the PBRN, not just being a research network. Three of those drivers were the Health IT and Meaningful Use program legislation that supported implementation of electronic health records in primary care and meaningful use of those records in primary care. The second is the definition of a patient-centered medical home and the development of a recognition process for what defines a medical home, and practices being asked to undergo wholesale transformation, wholesale change of the way they deliver care to patient populations. And then thirdly, a little known but actual quite interesting aspect of the Affordable Care Act. It's Section 5405 that talks about the need for this infrastructure for primary care, the Health Extension Agent Program, that ideally should be a national infrastructure with actual extension agents, much like the agricultural cooperative extension agent model. But it's a program in which extension agents go out and outreach to individual practices, work with them around improvement. They're boundary spanners, they're disseminators, they're people who collect questions or identify problems and bring them back to the academic office and say, hey, there's a problem out here that we don't know the answer to. Can we do some research around this and get them an answer to help them deliver better care? All of these have really placed a lot of challenges and demands on primary care practices, and these are the practices that are members of these PBRNs. And as a result of these demands, the member practices are challenging the PBRNs to take a more active role in helping them with these challenges. Next slide. And many PBRNs have been involved in this for quite some time, which is professional development activities. Not only traditional CME kind of activities, but also like Project ECHO. And Lyndee is going to talk about Project ECHO here in just a minute and give you a little bit more details about it. But PBRNs have long been involved in developing learning collaboratives around chronic diseases like diabetes and asthma that really have improved the quality of care that clinicians are able to deliver for these. So next slide. So really we're talking about now a new vision for what PBRNs are all about. We're talking about not being just a research focus, but really a learning and improvement network, that it's a practice-based learning and improvement network is the challenge that's ahead of us now. And how do we do that? How do we meet this new challenge? We're listening to the members that are out there, and many of them are telling us, help. We need help. There's no infrastructure out there for this. How can you help us do this? Or as research networks, as leaders of research networks, many of you are seeing your practices struggle and saying, how can I help the practices with the challenges that they're facing? So I think that's next slide. So we're going back to the old definition. This is the original definition. right? United by a shared commitment to expand the science. And here's what we propose for a new definition, that it's really, a PBRN is really a partnership between primary care clinicians, researchers, and other outside related organizations that are united by a shared commitment to continually improve the delivery of primary care through systematic inquiry that develops new evidence, but also support for continuous quality improvement and dissemination and implementation of best practices and evidence out into practices. So that's where we are, and that's, I think, where we're headed next with PBRNs. So I think it's next slide. We're going to turn it over to you. Lyndee, do you have any comments for me, or I went through that kind of fast? I feel like I kind of rushed through it.
No,
Maybe it's because I'm on my third cup of coffee, but.
Well, that's because I got you up so early this morning to practice, right?
Probably so.
Not right now. I thought that was very clear and creates a nice foundation for the part that I'm going to talk about now. And I asked Mike if we could do this a bit as a conversation. So as I talk about the workforce of the future and the workforce that PBRNs will need to fill this emerging and new agenda that PBRNs are positioned to operate in, I've asked Mike to converse with me, and I also want to share that in preparation for this, the area that I've been doing a lot of work in is practice facilitation. But I also reached out to Wilson Pace, who's running one of the big data networks, and to Jim Mold, and had a number of conversations with people at AHRQ and also with Mike. So the information here is a combination of all of these people's thinking, not just mine. So the first question is, what skill sets do PBRNs need to function as learning and improvement networks? And there's basically 5. There's training, health IT optimization, research and development, implementation and improvement, and then the ability to influence policy. So I'm going to walk through each of these and talk about some of the skills and competencies that live in each one of these bubbles. So the first and most prominent is really the skills in quality improvement and practice change. And so we're looking at an evolution of the PBRN workforce from straight-up research assistants who went out and collected data and coordinated research studies to practice facilitators. And these are individuals that have that skill set, the skill set of the research assistant, but much, much more. They have deep skills in quality improvement methods. They can workflow map. They can do audit and feedback. They're able to benchmark data to local and national standards. They're able to identify people and bring them in to do academic detailing with the practice. Academic detailing is a type of peer-to-peer exchange, and they facilitate making that happen. They're able to train practices on the model for improvement and PDSA cycles, and then help facilitate practices in implementing and using that process. They're very effective at team building, not just with quality improvement teams, but also with care teams. So conflict resolution, working with people's personalities. I talk to my folks about the fact that practice facilitation and this type of work is really about managing technologies and personalities. And then they're able to, this is a statement, the Hope Energy Action really comes from the work of Paulo Freire in South America, and comes from the work that I do with community health workers. And practices and clinicians in practices and their leadership also need this ability to believe that change is possible. And a key function of that quality improvement facilitator, the new workforce of the PBRN, is to help practices even believe that change is possible. The second bucket of transformation, implementation, improvement skills that our practice facilitators need, our new workforce, is really that ability to help practices implement specific new changes, to redesign their practice, to set up empanelment, to help practices form care teams, move from the solo doctor to the care team. And many practices have done that, but the ability to actually function as a team is still lagging far behind. And so practice facilitators, this PBRN workforce, because of the relationship they have with the practices and because of this enhanced skill set, that they're developing are well positioned to help care teams optimize their functioning. Training staff on population management skills and the use of health IT for that, patient-centered care and concepts of that, enhancing self-management support, helping to set up care coordination capacity within the practice, engaging leadership in change. And one of my lessons learned in the field is you can have a wonderful physician champion or clinician champion, but if you don't have the leadership on board, you're dead in the water. So really being able to reach out and engage that leadership and get them involved and motivated. And then support doing organized evidence-based care, implementing guidelines. So another bubble that you would notice on that first slide is health IT optimization. And this is something when LA-Net started working with practice facilitators, I did not realize how incredibly critical these skills were. And this is something, at least in my community with the medium and larger sized federally qualified health centers, has just become critical. And I'm to the point where I almost feel if my folks can't do this, then we shouldn't even show up. Because everything is so now driven by the ability to use, access, and optimize electronic health records and other IT systems in the practice. And so if you look at these skills, the practice facilitator skills and practice transformation and redesign, the ones in red are really the ones that are very strongly impacted by health IT. Empanelment obviously is. Care teams and the ability to do tasking and use the EHR record as a way to coordinate care across a team. Certainly population management, to be able to see your patient population and who needs what, to be able to do proactive outreach to these patients and bring them in rather than reactive care is the way it's typically described. Care coordination, to be able to see the resources being used and accessed and helping to coordinate and help the patient navigate through that. And surprisingly enough, engaged leadership. One of the things we found that really gets the attention of practice leadership is data. And to get to data, you've got to be able to work with the EHRs. And the benchmarking and being able to do the audit and feedback is one of the most effective ways I've found to getting leadership paying attention and engaged in the process. And then, of course, for the guideline implementation, having templates and point-of-care decision supports and these types of electronic health record capacity in the practice.
Lyndee,
Yes,
how much of it is about the technology and figuring out how to get the technology to do what you want it to do, and how much of it is about the human EMR interface in terms of helping practices figure out the workflow around health IT?
I think right now I would say it's about 50-50. We spend right now out in the practice, I'd say 80% of our time trying to work with the EHRs, correcting mapping errors, trying to set up registries, that type of activity. I think we're slow at it because we don't have that deep skill set, and we're actually moving from a single practice facilitator model to a team-based model and bringing in consultants or like subcontracted people to come in with the health IT expertise. So my guess is when we add that expertise, the time and investment in that will go down because these folks will be much more efficient. And then the other is really getting the practice using it well. It's interesting. I was working with one of the CMOs of one of the federally qualified health centers that we support, and she had had a facilitator come in and map the clicks. It's workflow mapping, and I'll get to that in the next slide, is basically mapping EHR clicks now. And so to be able to do workflow mapping, you need to be able to work with EHRs. And she showed me, the end product of this facilitator's workflow mapping of their EHR, and she said, I didn't even know it could do half these things. And you could see she was thrilled with it, but she also didn't know they could do it. And so that's the kind of engaging the person side of it, is helping them see and utilize these systems to their full capacity, but at the same time, not letting it interrupt the patient care process. And so we hear a lot now about patients and providers communicating even less because the provider's looking at the computer, and so developing whole new systems where they're able to use the EHR system but still have that very personal encounter with the patient. Does that answer your question, Mike?
Sure. Thank you.
Right. So here is additional, when you get into the quality improvement, again, that kind of central role of health IT and the ability to work with those systems to do audit and feedback and benchmarking and those types of things. So talking about this workforce of the future for PBRNs, there's a real need for deep skills in health IT, the ability to set up registries, to train practices to do this, and then not just to train them, but to be able to institutionalize it in job descriptions, in employee handbooks, in training manuals, because another thing we've experienced a great deal of is turnover. Almost every CMO in my federally qualified health centers has moved or left the field in the last year, as well as a great deal of staff. And so we've gone and we've trained, and we go back and that person's gone, and the knowledge is lost to the organization. So it's not just setting up and training people in these skills, but creating a system, a knowledge base that can help sustain that over time. Things like correcting mapping errors, creating templates, creating flow sheets, training, again, the practices to do this, being able to access data, both for quality improvement, also for panel management, population management purposes, and also research. The ability to set up and generate reports and train the practices to do this. And Mike asked me a very good question. He says, well, are the facilitators doing this, or is the practice doing it and the facilitators training? And I think my answer to that is both. That sometimes practices are overwhelmed enough, and it's a type of one-time activity, such as setting up a report template, that once a facilitator does that, kind of bumps that practice to the next level where they can begin to actually really use it. So sometimes it's training, sometimes it is some doing for that practice. They're able to work with practice IT staff who are a very different animal. They're a very different bird. Their motivations are different. Their interests are oftentimes different. Their personalities are very different. I found it very challenging, the typical brownies and you know, listening well kinds of approaches that my facilitators have used don't work too well on the IT staff. So it's learning how to work and engage with them and what matters to them, and then also the super users in the practice. Knowledge of vendors' tech support, that's another thing that we found our practices don't know what they are contractually able to access, and oftentimes don't have the time to ask for that support, as well as almost all the IT vendors have learning communities of their users where you can exchange ideas, getting them hooked up into that. Able to work with vendors to make changes. One of the most important outcomes that LANet had on a recent project that we did with Jim Mold on CKD guideline implementation was actually working with the registry product that many of our practices use. It's a program called Eye to Eye, and getting them to remap the norms for CKD patients. They had the system was set up so it didn't accommodate African American patients in CKD norms there, EGFR norms. And so we were able to actually get the vendor to do some new programming and change their product to support that. That has huge impact because it's affecting, you know, many people in California, not just our local area. And then also being able to do health IT type of optimization that supports PCMH, implementation of the care model, meaningful use, and then finally for research participation. So the next
Can I
area,
ask a question?
Sure.
I think if I was listening to our presentation now, I'd be saying, well, what does that have to do with being a practice-based network? Because shouldn't the vendors be doing this for the practices? What about the high-tech rec, which I understand the funding for those are going away later this year, but why should this be the role of the PBRN?
Well, to me, Mike, it may vary region to region, but the PBRNs, our PBRN oftentimes functions as a bridge between the academics and the community, and in this instance, really a bridge between the vendors and the clinics. Oftentimes the vendors are very interested in setting up the system, but the systems, unfortunately, are not designed to support patient-centered medical home types of care and care model types of care. And so it's been very frustrating. Like almost none of the EHRs, I would really just say none of the EHRs running out in my area have good registry function. And how can you do population management or any of that kind of work without an effective registry? So much so that our practices are contracting on the side for a separate registry program that's very effective, very elegant, very useful in population and panel management. So the vendors just, and I know I'm on a large audience, or afraid I'm going to say something I'm going to get in trouble for, but they're just not very sensitive, at least in our area, to many of the needs that our clinicians have to be able to practice the way that they want to practice.
Is this a way for you to? Is this a way for you to better build trust and relationships with your practice by doing this?
It makes us very useful. It makes us relevant. In our practices, there's so many competing demands now, and I've shared this with a number of my colleagues in the PBRN world that I've had, 2 CMOs tell me, if you guys can't come help us use our EHR better, don't even bother to show up. Because right now we're so overwhelmed with that we just don't have the bandwidth to do anything else.
Yeah. So it makes you relevant to your member practice. Yeah. Yeah.
Exactly. So that's why we're moving very aggressively in trying to add that skill set, because we feel to continue to be a partnership with our practices and a resource for our practices, we just have to have deeper skills in that area than we do.
Sure.
And I found it hard to make happen because many of those folks are already contracted with the high-tech recs. In some places, for example, North Carolina, and there's a wonderful case study about North Carolina's practice facilitation program at the AHRQ website. And they house both the quality improvement transformation and the high-tech rec. And so it's very integrated. But in my area, they're not. The high-tech rec is mainly focused on implementing the EHRs, not on really changing care, and certainly not on doing kind of more practical applied research work. So does that answer your question?
Thank you.
Okay. So the next bubble or area, bucket of skill that is really emergent for practice-based research networks is that of a training educational function. And Mike mentioned Project ECHO. He mentioned the CDN. It's the ability to, from a quality improvement perspective, support things like learning collaboratives. And then Jim Mold has been experimenting, and we participated with him on the use of local learning collaboratives, which are very small, 2 or 3 practices get together and share their ideas, usually virtually. Dissemination and education programs, like Mike mentioned, the Project ECHO and the CDN. But there's another function that, from my conversations with people at AHRQ and other areas, is going to become very, very important for PBRNs, and that's the ability to create toolkits, educational materials. I don't know if it will include videos. I'm getting very interested in the use of videos to help change behavior and communicate complex concepts quickly. But the ability to do curriculum development, toolkit creation, educational material development, and then staff that understand effective learning methods, adult education, working with adult learners out in practices, and then the capacity to support learning networks like ECHO or the CDN. So, Mike and I this morning we're doing some more talking about, so what happens to research when we look at the trajectory, the developmental course? And hold on just a second, I think I'm getting a... Oh, no, I thought someone said they were having trouble hearing, but that was something else. So what happens to research? Money, here's the statement or the kind of gist I get, is that money for interesting research with no clear payoff is going to get harder and harder to get. So there was a period in the kind of development of PBRNs where the ability to pursue interesting research that doesn't directly map to triple aim types of things, improved patient experience, improved patient outcomes, improved and lowered costs, there was funding available to explore, and that money is going to get harder to get. And so the skills in research that PBRNs are going to need to develop, and many of them already have this in spades, but is skills in conducting applied research that can be directly and quickly impact practice. And then I had a very interesting conversation with Jim Mold last week about the idea, this is a longer-term vision, that when the primary care extension program is up and running, that PBRNs are ideally positioned to serve almost as the experimental farms for the extension program. And so in that case, they're going to need skills in being able to field test new processes, interventions, and then tweak them before they go. The PBRNs might be that step right before the extension program disseminates. And maybe many PBRNs might house both the practice facilitation QI capacity and this field testing capacity in the same organization. So the types of skills that a PBRN will need, and again, this I think our community already has down very well, and I know Victoria Neal has done such wonderful work and Rowena Delore in this area, but doing applied research methods, being able to do best practices research, looking at variation in performance and identifying those high performers and studying what they do and then spreading that. The capacity to turn results around quickly so it makes an impact. It can't be 3 years down the road before the results come out from the research anymore. And then, this is a real serious potential rate limiter is PIs that are interested and able to do this work. Those located in universities may really struggle, especially on tenure track and that type of thing, to get engaged in this kind of activity. So it's looking at where do those PIs come from, the clinicians out in the community, maybe more progressive thinking universities. Skills in recruiting and retaining highly motivated practices, which has always been something we've needed. And then this last one is really this ability to engage and work with key partners, such as public health, to address questions that, again, getting back to that idea of being able to have real, relevant, immediate impact with our research. The field testing skills, the methods to test and tweak guidelines, comparative effectiveness research findings. Jim Mold told me a very interesting story about a number of years ago he was trying to implement guidelines in his practices around managing heart failure in his patients, and there's the two types, there's the floppy and the stiff. And the committee that had formed that guideline was made up of specialists who typically saw the floppy type of heart failure profile. But yet in the primary care setting, they were seeing mainly the folks with the stiff version, and so the guidelines were almost unimplementable in the primary care environment. And he talked about how valuable it would have been able to have a PBR in partnership with that guideline development committee to really be able to inform what they were doing and to understand what was actually going on and needed in the primary care setting. The final area in terms of skills and workforce and research is really working with big data. And this is the work that Wilson Pace is doing through DARTnet and the Safety Net, Practice Partners Network. And that's something that we're not going to cover in this session, but that's a whole nother set of skills that some PBRNs may be interested in building. So the final kind of bucket is this informing and influencing policy. And so this ability to, we talked earlier about forming partnerships with health plans, local and state health departments, health authorities, IPAs, really to engage with them around areas of concern. And for example, in our area, the health plans are very concerned about repeat admissions for patients that have gone in for heart failure and other types of concerns, the transition from the hospital to the community. They're very concerned about the poorly managed diabetic patients, about issues like obesity. And so being able to work with them and partner with them to help address some of those questions. The ability to provide timely and relevant information effectively to the people that are setting up these local or even state-level guidelines, state-level policies. So I wanted to share with you just quickly a project and just illustrate what I've been talking about, Mike and I have been talking about with one of our projects. LANet, a couple of years ago, decided to implement Project ECHO. And for those of you who are not familiar with Project ECHO, it's a virtual learning community for knowledge and skills development in areas that are common but complex. So a mentor specialist one time a week or once every other week mentors primary care providers out in the community. And the idea is to build their capacity so they can begin to eventually accept referrals and then co-manage in the community and co-manage those patients through these knowledge networks with the specialist. We learned about Project ECHO from the PBRN community. We learned about it from Rob and from PrimeNet. About 3 years ago, I remember being there, and Rob had Project ECHO come in and do a presentation, and I thought, we need to bring this to LA. And then I spent probably 12 to 15 months trying to get support, get those opinion leaders in the community that were interested in bringing it. Got that. We partnered with the local health plan, so this is that idea, again, of local relevance. You know, does Project ECHO work in the LA Net Safety Net, in the LA Care Safety Net, in the LA Safety Net? And then the ability to partner with local organizations, the health plan, our managed Medicaid health plan, LA Care. And so they funded us to implement and test Project ECHO in the LA Safety Net. And we did this with 21 practices. We had 27 providers and care teams that participated, and we ran 20 sessions. And what we were looking at is really kind of that first and second order change of, you know, who adopted it, you know, since it was developed in a rural community, could busy clinicians in urban settings even join a session? You know, what was their motivation and ability to participate? So we looked at participation rates. We had them self-report on its impact on their care decisions. We looked at their satisfaction. And then we studied the resources that LA Net as a PBRN or an organization in LA, as well as the primary care settings and the specialty care setting would need to be able to implement and take this to scale. It was wonderful. We're just kind of coming to the end of the initial demonstration and getting ready now to move to the next step and set up our first, what Dr. Aurora calls Center of Excellence, in one of our federally qualified health centers, who will begin to accept referrals from the surrounding community and other healthcare settings that don't have adult psychiatry capacity. But to do this, we're going to have to change some policy. There's certain IPA rules that prevent internal referrals of this type. The capitated payment structure is a challenge for the FQHCs. There's referrals across medical service areas in LA. There's many barriers to making those happen, and we have a community health center and a community mental health center that are both wanting to send patients to the Center of Excellence. The Medicaid waiver is another issue, some of the requirements and restrictions there. Certainly, you know, some of HRSA's requirements. And so we formed a feasibility study and have partnered with a policy analyst to help us kind of identify all these barriers as a means to be able to take this to scale in LA. So very different than the types of, you know, very circumscribed research projects that we were doing, say, 10 years ago. So what does this all mean for PBRNs and their workforce? And Mike, do you have any questions, or should I keep going?
No, I think you're doing, this is great. Thank you. Okay.
So really, it's back to that message that that I kind of integrated into the slides at the very beginning, is that the key staff role in a PBRN is really evolving from a research associate to a practice facilitator. And this is an individual, or in my case, a team of individuals with skills in data collection from IT and traditional sources, quality improvement methods, implementation of best evidence and practices, as well as elements of the care model, patient-centered medical home, supporting meaningful use. It's an individual or team that's able to optimize health IT and the practices for quality improvement, for changed models, redesigned practice, and also for research. It's someone that is very good at dealing not just with technologies, but also with personalities. It's doing team building with the practice, with the quality improvement team, with the care teams. It's doing leadership development. I'm beginning to play with the ideas of sending my facilitators to executive coaching training, because many times practice leadership are clinicians that were fabulous clinicians that have risen into administrative roles, and that's not an area they've been trained. And they don't particularly enjoy it. I think that's part of, at least in my world, where many of our leadership are burning out. And oftentimes it's because they haven't had an opportunity to build those skills. So looking at whether that's another kind of area of relevance that we're starting to play with. Can we do that for them? Can we become a service that that helps provide that for them. And then the other one is managing a multi-role relationship with practices. So you have this tradition, practices joined because of the research. Now it's evolving into really a service organization that's providing quality improvement support, also supporting research, helping to do much broader range of practice improvement and transformation. And so really this person also has to know how to help the practices understand who they are and the different roles that they play in the practice, from someone managing a research project to someone that's there to help support empanelment, someone who's there to optimize the health IT and the quality improvement team. So I've gotten where I've started. My new thing is to think of our facilitators as really like the Swiss Army knife of primary care, that they come with many, many different skills. Again, it might be an individual, it might be a team that are there to really go back to that mission that Mike laid out to really optimize and improve primary care across the country.
Lyndee, I want to go back.
And then obviously,
I want to go back and revisit a concept that you also mentioned earlier about, rather than the practice facilitator being everything to everybody, that there are times they bring in the academic expert or the content expert in a particular area for consultation or support about a specific issue or topic, but they're not always the one doing everything for everybody in the sites.
I think you can think of them almost as a vector for many of these things, or the capsule that delivers the medicine to the practice. So they might go and find, like we have this wonderful internist who's an expert in CKD, David Martins, and so he was the academic detailer for one of our practices, and the practices loved him. And it wasn't my facilitators delivering that knowledge, but they delivered David Martins and made sure that the practices were able to interact with him and that the sessions were recorded, so if people missed it, they could see it. They advertised it. They helped Dr. Martins pull his things, that kind of thing. And so the same thing when you're bringing in the vendors to provide the tech support, or you're working on a team and you bring in your IT expert. Again, North Carolina has a very interesting approach in that they have not a facilitator, they have a facilitation team that's composed of a QI coach, a health IT optimizer, and then a data person. So that expertise may reside in multiple people.
Lyndee, this is Rebecca. I have a quick question.
Go ahead, Rebecca.
With respect to practice facilitation, what is your view, or have you seen evolution of engagement with patients by the practice facilitator? How do you see that proceeding in the future?
Well, I guess there's two levels of that, and one area that our facilitators are really beginning to think and look at a lot is self-management support and optimizing that for patients. And also looking at an extended care team that includes community health workers. And so we have some projects going on with several, actually a large integrated health system to use facilitation support to integrate community health workers on care teams, and what does that look like, and how does the communication between an MD and a lay person work, and how do you make people feel comfortable and transmit information back and forth. So that's one level, is how do you make the practice more patient-centered, more relevant, and how do you help the providers, for example, develop shared care plans and that type of thing. So really focusing on processes and procedures and expanded care teams. The other is straight out partnering with patients as a member of the quality improvement or facilitation team. And we have not started doing that. Linda Cole in Humboldt has been doing some work in that area, and we have a contract with the VA in Los Angeles, and they incorporate veterans as part of their kind of larger quality councils. And so we're just beginning to look at, and I think this is going to be really dynamite when we can make it happen, is getting one of our practice facilitators, almost like a duet, a partnership, a dyad of a practice facilitator and then a patient partner. And how do you train those? And I had a conversation with Linda, it was a while ago, but my understanding is she'd actually developed some curriculum help train practice facilitators to partner with patients in quality improvement and practice transformation work. And then how to work with practices, because it can be very intimidating for a practice to be open to, and get feedback from a patient, because it feels, much more like criticism. And, what if we show our bumps and our warts? Maybe it creates problems for us, that kind of thing. Does that answer your question, Rebecca?
Oh, that was a very fulfilling answer. Thank you.
Oh, I'm glad it was fulfilling. Oh, it makes me happy. What a nice word. So depending also, in addition to the practice facilitators, other skill sets, like the education specialist, the person that can develop your toolkits, training curricula. We actually hired about almost a year ago now an educational specialist, and she runs our ECHO Knowledge Network, and then she helps us with adult education theory, and we've developed some curricula recently, and we've obviously been doing some work in developing toolkits, and she's been an invaluable resource for that. Policy expert, and we can't afford to have a full-time policy person, but we have now about 3 or 4 people that we can reach out and tap and contract with to have them help us develop white papers or think about how best to communicate this to a payer or to a legislator that might produce some reflection on the policymaker's part and some potential change. And then PI is able to do the applied and best practices research. And because we're located outside of a university setting, we're struggling right now with having sufficient PI. So anybody in the audience that wants to partner with us in PI, we would love to have you. But for many in the academic health center, maybe this is less of a challenge, but really developing a new type of PI that's interested in this applied science. And then even the local universities, it's challenging because many of the young academics are on tenure track, and this is not the kind of work they're going to get tenure for. So last kind of slide about skills and workforce, but what does this mean for PBRN directors? So you've gone from basically a researcher. That's how I got started. I was an academic in the Department of Family Medicine at USC. And the funding announcements came through from AHRQ and then also from HRSA, and we started the PBRN. It was really for our faculty, and then we grew out from there. But that was the skill set that I came to this with. And now with this new expanded role, and I think very exciting role for PBRNs, I just think we're so positioned to really just, be a catalyst for a new type of primary care across the country. But you have to have one that knows how to recruit and manage a practice facilitator workforce, has to understand quality improvement and practice improvement activities and practices. You can't manage what you don't know. You have to understand that process. That are able, as I was saying, to pursue an applied research agenda in a way that's not going to harm their professional trajectory. And a research agenda that will have obvious and rapid impact. It's highly relevant research. Local research, engage and work with new partners. Somebody that's good at reaching out and figuring out what matters to health plans and connecting with them and listening to partners at that level, state and local health authorities, working with IPAs. So it's really a very expanded skill set for the director. Then a lot of what I'm finding in my role is I'm a talent scout. It's really being able to identify and recruit additional talent that can do the toolkits, can do the health IT, can do the policy support, and then keeping them happy, which I find sometimes challenging. That's able to find funding for this type of quality improvement work and applied research work. And Rebecca, some of that I'm hoping is going to be your job. And at the recent NAPCRAG conference, I was very excited with some of what you were sharing, but it's not just going to be probably AHRQ and NIH and places like that. It's also going to be health plans and perhaps ACOs and even local foundations. And then as the primary care extension program gets launched, maybe there's different funding streams that kick in there. And then, again, back to that idea of helping practices that joined initially for the research understand this kind of expanding role and the potential of PBRNs and understand the multiple hats that PBRN staff may be playing. so they can work very effectively still with the network and with its facilitators and staff.
I just want to emphasize the partnership aspect of that for PBRNs, because I don't think we fully yet appreciate this. I am much like Lyndee. I came up in an academic department of family medicine. I got research skills. I knew how to deal with clustering within practices for sample size calculations and all those kinds of things, and then discovered as I engaged with a large network of practices that one of the important pieces of the puzzle was partnering outside of the academic health center and looking outside directors and thinking about the future of what skill sets do PBRN.
And I think, Mike, there also, when I got started at USC, I understood research, and I understood especially community-based participatory research. That was really kind of where I came at this from, and so it was a natural fit. But I didn't have an expansive knowledge of the health system in the LA area or in the state, or things like the California Medicaid waiver, and this is all knowledge that I'm actually still having to build.
Yes.
And so it's a very different also body of knowledge that I think the directors have to, because otherwise you can't be relevant to the health plans and to these partners. You're not going to be able to attract their attention.
Exactly.
So you were talking about your SPSS. I was reminded of that wonderful joke about statistician is what is a statistician that's introverted looks at his or her shoes, and the extroverted statistician is the one looking at the other person's shoes. I love that. Stan Azen told me that years ago, and I've never forgotten it. Okay, so now I've turned on this thing, and I don't know how to turn it off. How do I turn it off? Okay, so conclusions, and I wanted to play with that tool. I've never gotten to do that. So conclusions and wrap-up, and Mike, I'll turn it back over to you.
Yeah, this just gets back to the point that I really think we're at a crossroads. There's a demand out there for skills sets for implementation and improvement that really no one else is filling in most settings. And it's a real opportunity for PBRNs to be a catalyst for this because PBRNs are natural partners for this. And there's an opportunity to increase the diversity of what PBRNs do, to think about expanding their mission and their role, to practice improvement, and to really take ownership of this area, or at least find ways to partner with other outside organizations in this effort. So next slide. So things to think about for if you're involved in a PBRN right now is to look for opportunities to collaborate with health plans, with QI organizations, with others who have a stake, others who have a role in improving primary care practice and patient outcomes. And think about how to align the PBRN's organizational structure and resources with the needs of both the member practices and these other stakeholder organizations. But also to begin working with your member practices to clarify the role of the network in this learning and improvement activity in addition to research, and helping the members think about what does that mean for us as an organization. What should our mission statement be as a network? A lot of these networks originally started off calling themselves PBRNs, but evolved and are now called practice-based, as in Oklahoma, the Oklahoma Resource and Research Network. Or Lyndee, your LANet is now the LANet what?
We call ourselves a Resource and Research Network, too.
A Resource and Research Network. There you go.
Imitation is the highest form of flattery. we copied Jim. We thought that was excellent.
There we go. So be thinking about who you are in terms of your identity and your mission statement. Next slide. And then look for opportunities. How do you create opportunities for your member practices to learn from each other as well as part of your overall strategy? The convening function of the PBRNs we found was an important function, but also just the opportunity for practices to learn from each other and to find out what each other are doing. And we've even seen PBRNs where once a practice learns that some other practice is doing something really unique and innovative, in one instance they closed their practice and did a field trip. They took the members of their practice over to this other site to visit them, to figure out how they did that. And especially around health IT issues. Like, how do you make your system do that? How do you figure that out? And find ways to help practice learn from each other. So I think that's the end, isn't it? Next slide.
Yeah,
the resources.
Resources that are available if you're starting to think about developing a practice facilitation workforce, transitioning your research associates to the Swiss Army knife model. AHRQ has published several very useful resources recently. One is a how-to guide on developing and running a primary care practice facilitation program. I mentioned some case studies. There's 4 case studies of practice facilitation programs. One of them is Jim Mold's, which is located in a PBRN. The other 3 are not necessarily in PBRNs, but it's still very, I think, informative to see how other people have gone about building this type of a workforce. And then just recently with Cindy Brock, there's a practice facilitation handbook that has some training modules for new facilitators and their trainers that can give PBRN or other organizations a place to start, like a practice facilitation 101 for their workforce. So I guess we're at the questions and discussion. So, Kristen, do you have, let's see, I'm seeing. Mike, do you want me just to read some of these, or can you see them too?
Why don't you just read them? I don't think I can see them.
Okay. So your discussion sounds a great deal like the function we connect with our sites, although we aren't a PBRN yet. But our experience is that we get things done with clinical data in spite of the EHR vendors. So my question is, does the mission of the PBRN contradict the mission of EHRs? That's an interesting question. Mike, you want to take that?
No.
Don't say that.
Does the mission of the PBRN contradict? So is it? So read the question again.
So my question is, does the mission of the PBRN contradict the mission of EHRs? Cecile, would you maybe write a little bit of clarification on that, or Mike, do you have?
Sorry, I don't know what the mission of the EHR is. I mean, I know EHRs are, their underlying premise is to create a system to document what happens in patient care, both for billing and documentation purposes, and they weren't created necessarily for the purpose of doing research. And frankly, we're finding they're not really created for the purposes of performance improvement either. And that's what Lyndee was talking about, the HIT optimization piece, which is how do you get health information into some way that makes sense to those who are delivering the care about their performance and how to improve it. Because that has not been the underlying assumption behind most EHRs in terms of their structure, their underlying programming and code, and so that's been a real challenge.
So here's another question of who are the practice facilitators and how are they supported? And so I can talk a little bit of my practice facilitators, and I've had about 6 or 7 that we've trained. Right now I employ 2 full-time practice facilitators and about 3 that I contract out for. And they, backgrounds of those folks, many have masters in public health. I have a couple of RNs. I have a social work, a recent graduate from social work school. I have a PhD in education and ed psych. And so the common feature of these folks is that they're good at working with people, and they're not afraid of technology. They don't have to be uber experts because, again, I'm moving toward a team model and really bringing in health IT folks as part of the team. But mainly they're very good at working with people and facilitative relationships. So I come from clinical psychology, and I used to do a lot of family therapy. And having a good relationship with a person doesn't necessarily mean it's one that produces change, because sometimes change is painful. I think about it when I'm driving across town and they're repairing the roads, and I get angry and I get irritated. But in the end, it makes for better infrastructure. And so you have to have a person that is able to build and sustain relationships that sometimes are difficult and are able to kind of push the practice to move forward. So that kind of skill set rather than the degree matters a lot to me. And then how they're funded. At this point, I've been funding them with really dissemination and implementation research grants out of AHRQ, and then some contracts with health plan. We had our first federally qualified health center actually contract with us directly for support in one of their PCMH application processes. And then we partner with researchers and support their research. Most of them are NIH researchers, but we require that they pay for our staff to do the data collection and coordination. And so we're able to use some of that to also continue that relationship and QI support with the practices as well. And we also try to build in some of that data becoming a source of QI data for the practices. So do you want to add anything to that, Mike?
No, I think you did a great job. I think it's a combination of people skills and having really good people skills and not being afraid of health IT systems and not being not being intimidated by the fact that they're dealing with busy physicians and clinicians and office staff, and feeling comfortable and feeling like they have something to offer them.
So here is another statement, a very interesting one. It says, it would be interesting to see how many of the existing PBRNs are already pursuing these avenues of activities. My guess is that the minority are in the old PBRN research mode. So the idea that what we're talking about is already in full force out there in the PBRN community. And very few of the PBRNs are just pure, straight-up research at this point. Any thoughts on that, Mike?
Well, in the recent, I can tell you that from the recent AHRQ registry poll, that we are seeing more and more PBRNs that are reporting that they have or in the process of developing infrastructure for practice improvement, but it's not yet the majority. It's not yet 50%. If memory serves me correct, it may be around a third of the PBRNs feel like they have some infrastructure for doing this kind of work. It doesn't mean that people aren't wanting to do this kind of work or interested in doing this kind of work, but it's still something that's under development.
And then here is a question that I think we answered from Randy about where's the online article that mentioned the PBRN activities in the high-tech rec in North Carolina. And Randy, that's number 2 on this slide, the new case study. So if you go to the AHRQ website, and you can just, I believe, Google AHRQ and then PCMH, and you'll end up, those two will take you to a site that you'll find eventually the case studies and the how-to guide.
Yeah, it's pcmh.arc.gov. If you go to pcmh.arc.gov and then look under practice facilitation on that website, you'll eventually find the case studies.
I'm going to try to edit, but it doesn't let me do that. Okay, so I don't see any more questions. Do we?
So thank you very much, Lyndee and Mike. That was a wonderful overview. And as long as we have an audience, also having an opportunity to have quality improvement as a goal. And that type of vision is welcome, though all people will not choose to go there. And Mike gave a wonderful overview of the history of PBRNs and what they are. Just reflection and being in review meetings for grants recently. It's really important when you send in a grant proposal that you articulate well what a PBRN or what your particular PBRN does and how its experience that would occur there in a research setting is definitely valid and translatable to other settings. The PBRNs have continued to grow, and you are going to other fields of opportunity and challenges, but we're finding both at AHRQ and perhaps elsewhere that the familiarity with the PBRN concept does not permeate all the reviewers of the grant application, so make sure you put forth a strong, well-articulated presentation of what is unique and valuable about PBRNs so that others can recognize what you can provide as a research setting. So that came to mind. What you see, and also the last issue raised by Lyndee with respect to a reference with by Cindy Brock, who has led with the Practice Facilitator Guide that it has just come out. We will be convening a PBRN-supported webinar sometime this fall or winter with Cindy and others to share that particular toolkit and other resources with you. You see a list of some other upcoming webinars. It's a mixture of purely PBRN AHRQ-sponsored webinars and the Health IT team. So on August 6th, the Health IT, through the Health IT, we're going to have a presentation of 4 projects that were conducted by PBRNs with respect to use of Health IT in primary care. And as both Lyndee and Michael mentioned, there's a lot of interfacing and research with respect to PBRNs and Health IT. So August 6th should be a nice presentation. You can earn 1.5 CE credits, which would be wonderful. Another presentation that's not listed here that's co-sponsored by the Health IT team is on September 13th. Myself and Christine Martin Anderson, we're writing a report with respect to our findings on Health IT-enabled quality measurement and reporting that we will be releasing in early September. It goes beyond meaningful use issues. It talks about partnerships and the importance of working with vendors, as was discussed earlier today, though some of the folks implied that they were less than happy with the amount of interaction with Health IT vendors. But just as a point of information, in our response to our request for information about Health IT-enabled quality measurement last year and also in subsequent focus groups, the vendors were quite vocal and consistent about their willingness to understand and work with the clinicians and better learning what you need and how to customize or change the different functionality of the Health IT. So don't give up, even if you've experienced some challenges with your particular vendor. There are more vendors who are expressing interest. You had spoken earlier today about having practice facilitators that really are people and learning how to interact with one another. And I imagine some of the challenges of interacting between clinicians, administrators, and vendors is in the communication that you all are pursuing and tweaking that type of communication, but keep pursuing that. So if we skip back to the others, there on September 23rd, Dr. David West is going to give us an overview of connecting primary care practices with hard-to-reach adolescent populations and a guidance document that he has developed. And October 10th, Dr. James Warner and Jonathan Tobin are going to speak to us about mentoring researchers or practitioners in PBRNs. And they were very thoughtful in that the mentorship is not relegated to the new member of the team. But as folks' careers progress and their interests change and excitement comes up that some of the more established members of your team or who have worked elsewhere, they may seek new roles in the PBRN, and so that mentorship takes on different forms. So that should be rather fun in their presentation. And then on December 11th, we have the Theory of Plan Behavior and Implementation Research provided by dear France Laguerre. So if you were not able to join us at NAPCRAC, she's going to give her very vibrant presentation. And I must say, I found her personality and her drive and her care about providing strong, high-quality primary care to be infectious. So perhaps during December, if it's a long day, this will give you a good shot in the arm. When it comes to, if you have ideas on other types of presentations that you think would be very helpful, please send us an email to pbrn@abtassoc.com. We're trying to find good topics that are relevant to today's PBRN researchers and to facilitate the dialogue amongst larger groups of people and to learn what you're doing and get more information out to you that you would find to be of interest. So I found today's presentation to be very enjoyable, and I am pleased that so many were able to join us. And we look forward to next month's presentation on August 6th. And with that, I will give it back to Lyndee and Mike, but I say thank you very much for joining us.
Okay, Rebecca, thank you so much, and thank you for inviting Mike and me to do this presentation. And my thanks to Mike and the PBRN Resource Center and the folks at ABT for supporting these learning sessions. I think they're a great way for our community to expand skills and connect with each other.
Thank you, Lyndee.